Screen. Okay, can anyone see that?
Yeah.
Okay, perfect.
Okay, so just before we get into the actual presentation, just to introduce ourselves, my name is Jane Kim. I'm a master's student with Dr. Michael Krauts, and my research focuses on improving the health of vulnerable populations like the youth homeless through the possibility of using e-mental health as a process of early intervention. Andy, would you introduce yourself?
Yeah, absolutely. My name is Andy, and I am currently a third-year PhD student in neuroscience, and I work at the Addiction and Concurrent Disorders group alongside Dr. Michael Kraus. And my research has focused on elucidating high risk factors amongst the vulnerable population, specifically utilizing data from the British Columbia overdose cohort, provincial overdose cohort, and utilizing that data and kind of feeding that data into a machine learning algorithm to figure out what are the high risk factors and trying to create a tool. So we'll actually get to see parts of some of the results that I've had, and of course, machine learning, rule-based systems, and clinical decision support systems. We'll be discussing more of that in the upcoming slides. So thank you everyone for joining.
Okay, so a clinical decision support system, or CDSS for short, is very broadly defined as any type of system designed to aid clinical decision-making, where individual characteristics of patients are used to generate patient-specific assessments or recommendations that are then presented to clinicians. They're really intended to improve healthcare delivery by enhancing medical decisions with targeted clinical knowledge, patient information, as well as any other health-related information that is important to consider for the sake of the patient and the care system. It's important to recognize that CDSs are not a replacement of practitioners, but are for their own use to combine their knowledge with information or suggestions provided by the system. CDSs can also be computerized or non-computerized. Non-computerized tools can include things like clinical guidelines, such as clinical key or resources for the doctor or patient in printed form. Currently, CDSs often make use of web applications as a standalone system, or are often integrated with electronic health records and order entry systems. Next slide. So CDSs have a variety of applications, including patient support, data management, diagnostic support, and cost attainment. They can improve patient safety through reducing dosing errors or contraindications through laboratory alert systems and automated warnings. So for example, when a patient has an allergy to a particular type of drug, or is taking a drug that will interact harmfully with the new treatment, the system will respond in a pop-up or a notification to warn the pharmacist. These types of alerts are typically implemented within order entry systems, and these are really among the most disseminated kind of decision support we have currently. CDSs can also support shared decision-making by allowing the decision support to be administered directly to the patient along with the provider. This allows for additional knowledge of the patient and increasing their ability to choose their own trajectory of care. They can also increase clinician adherence to guidelines and help identify patients that need testing or preventative care or follow-up without the effort of having to manually check. When they're implemented properly, CDSs have shown to be cost-effective through suggesting cheaper interventions or reducing test duplications. And then finally, CDSs for clinical diagnosis are also known as diagnostic or medical decision support systems, and they provide a list of possible diagnoses for the patient based on clinical data that the clinician can refer to. Next slide. So most CDSs are structured in three parts. From the bottom up, they have the data management layer, the inference engine, and the interface layer. So the data management layer consists of the available clinical and patient data with the knowledge or algorithm used to model the decision from the system. It is a compilation of clinical information and evidence-based guidelines that serve as the representation of best practice. The Inference Engine takes this decision-making process and applies them to the patient's data to come up with like an individualized output. This output is then presented to the end user or clinician with the interface layer, which is the way users can interact with the system by entering patient data and using the output's information to make the final decision. As previously mentioned, these outputs can be in the form of diagnosis, alerts, reminders, or guidelines. How the decision is made within that data management layer separates CDSs into two types. In knowledge-based systems, the system often creates decision tree flowcharts with rules in the form of like if-then statements. So these models have the advantage of being interpretable by humans and following the logical steps based on medical guidelines and evidence. So people can follow through what the system is doing and kind of check to see if the system comes to the same conclusion as humans. In non-knowledge-based systems, the decision leverages more complex models such as artificial intelligence, machine learning, or statistical pattern recognition. And many of these are used to improve prediction of outcome, price treatment, or help choose the best course of action. Next slide. So given the components of a CDSS, we can imagine some expectations of its use within the current trajectory of care for, let's say, like opioid use disorder. For preventative care, CDSs can help screen for at-risk users and provide guidelines for users to learn more about how to manage the risk so that it doesn't develop into an overdose situation and disorder. It can also help primary care clinicians be able to recognize the signs of an OUD and guide people to the right area of care for timely intervention. When planning potential treatment approaches, they can guide clinicians to choose the right pharmacological or perhaps psychosocial interventions to maximize patient retention, survival, and of course, patient satisfaction with treatment. In particular, they can inform clinical strategies toward appropriate treatment goals for youth and other vulnerable individuals. They may be able to provide oversight over patient progress and monitor relapse or overdose situations. And finally, it can be tailored to the patient's needs and encourage them to be active participants in their own care by providing them the knowledge and tools needed to manage their own substance use. Next slide. So this is one example of a knowledge-based CDSS. So in the form of if-then rules for buprenorphine adoption in emergency care of individuals with opioid use disorder. So this kind of flowchart is integrated into a clinician's workflow in the emergency department. And it is available for guidance to determine whether patients meet criteria for OUD, to assess withdrawal symptoms, as well as initiate treatment and dosing in patients. Next slide. And this is the same CDSS in its interface layers, how the clinicians see and actually work with the system. Next slide. And then this is an example of a CDSS for the patient. So this example is WebMD's symptom checker, where people can go online and input their own specific symptoms to be kind of guided towards what the symptoms could possibly mean, as well as how they can be treated. There are, of course, some risks to CDSS as well. So one potential disadvantage is that clinicians could spend less time interacting with patients and more time interacting with like a computer or workstation. This is, of course, greater concern for vulnerable populations who may feel neglected from healthcare or impacted by socioeconomic difficulties that a system will not be able to account for properly. Secondly, the maintenance of CDSS can often be neglected. Particularly in knowledge-based systems, the decision-making process has to keep up to date with the current state of knowledge, which means like frequent updates and intellectual work. While working CDSs can help save money, their initial implementation and setup can also be substantial in cost, and staff will also need to be trained on how to use the system, which takes more time and effort. And finally, some studies have found that CDSS alerts can be considered disruptive if they're excessive or considered not really important to the clinician, resulting in further clinician fatigue or clinicians ignoring the notifications. Conversely, users can also develop too much reliance or trust on a CDSS for a specific task when they could be flawed or they could spend more time with the patients themselves.
Okay, so thank you so much, Jane, for giving us a brief introduction on what CDSs are, non-rule-based and rule-based system. So why are CDSs important, right? Like, why are we talking about it? Why are we presenting on it? Like, how does that help clinicians? How does it help physicians? So that we were also very interested in this topic at the Addictions and Concurrent Disorders group. And because of that, we started to create a systematic review. This is actually a second systematic review. Our first systematic review looked at machine learning models within addiction psychiatry, and we found around 50 papers or so, and that manuscript is about to be submitted. So this is kind of the second iteration of a two-part systematic review kind of papers that we've been working on at the ACD group. So the purpose of it is to investigate more on the topic of CDSs, and our hypothesis was that the utilization of clinical decision support systems can help healthcare and social workers in psychiatry and mental health. Our objective was to review the creation and implementation of clinical decision support systems in psychiatry. So we searched through 4 different databases: PubMed Central, Ovid Medline, Ovid Embase, and Web of Science for adequate coverage of literature. So we then imported all the papers, which was 6,645 studies, into Covidence, a systematic review online tool. There we performed title and abstract screening for all the papers, which resulted in 74 manuscripts that were relevant. Within these papers, 60 studies were included. And we've started some preliminary results. So next we'll talk a little bit about those results in terms of the qualitative analysis, as well as some interesting papers out of those 60 studies, some different trends, and then present some of those CDSSs in terms of like their workflow and their diagrams, and also present a CDS or an inference engine that I've created myself, and I'll talk a little bit more about that in the later slides. So then we imported the 60 studies into another tool called NVivo. NVivo allows for quantitative analysis for systematic reviews. And within those 60 papers or so, I had identified 3 different themes, which were study design, type of CDSS, and study population. And this slide shows the different study designs that the 60 papers had. Majority of literature were intervention studies that looked at the efficacy of CDSSs in psychiatry, with some that had protocol, or there were 15 papers in describing protocols, 15 that had qualitative analysis, which means like things like how do clinicians feel about utilizing a CDSS, and we had 6 reviews. Next, we can see that most of the published literature in CDSSs in psychiatry were rule-based. This means that majority of papers we found created inference engines from guidelines and expert opinions instead of utilizing machine learning techniques. This was a shock to me. As I previously said, our previous systematic review found over 50 manuscripts describing machine learning models in the space of addiction psychiatry. So not really applied in a CDSS setting, but machine learning models that are readily available and ready to be kind of embedded into these CDSSs to be pilot tested, et cetera, et cetera. So lastly, we can observe that there is not much literature on CDSS developed in psychiatry for children and adolescents. And this is also another problem. But I'll also talk about one of the reviews that I found in the children and adolescent population. Yeah, so next I'll talk about some of these manuscripts individually and some key papers I found that were quite interesting. So one of the key themes that we found is that CDSSs were being developed for rural or low middle income countries. This was interesting as CDSSs have the potential to increase access to healthcare in these locations with heavy burden of disease and low funding. So this can also apply to high income countries like Canada, where we want to utilize different CDSS tools to reach populations in more rural areas of BC, for example. Next, I'll talk a little bit about a paper that I found, which was a systematic review. We found one systematic review within the 60 studies or so that looked at CDSSs in children and adolescent psychiatry. Within the systematic review, they found 10 studies that utilized rule-based, again, evidence-based models to direct decision support within physicians. This is another key result because there is a lack of CDSS tools that utilize non-rule-based techniques, such as machine learning, that cover the child and adolescent population. This could be due to the lack of the readily available data on this population, sensitive population that is required by machine learning. Readily available big data, for example. Another common theme that we found in our systematic review is the focus on clinical decision support systems for medication. This area could be very useful as psychiatry is symptom-based, as we all know, and could use more big data for personalized treatment trajectories. On screen is a Texas medication algorithm, a rule-based, again, algorithm for the treatment of non-psychotic major depressive disorder. So lastly, here's an example of a mixed method system, which is utilizing both non-rule-based and rule-based methodologies to build a CDSS for mental and behavioral disorders in child and adolescent psychiatry. As you can see from the top, this is a system that uses guidelines, scientific literature, and practice parameters to create recommendations that get fed and interact with data that's collected by the system, such as the EHR and the user interface. And with that, it basically goes and collects and looks at healthcare records and healthcare registries and population statistics, and utilizes big data and machine learning to come up with individual trajectories. So to me, this is a really great system since it uses both rule-based and non-rule-based CDSS methodologies. So how is this relevant to the opioid epidemic? So as I previously discussed, the ACD group, we are within the field of addiction psychiatry, and currently we're working on a platform called the Risk Assessment and Management Platform. And within that platform, I myself have created the Inference Engine based off of data from the British Columbia provincial overdose cohort. And within this Inference Engine, I use machine learning techniques to predict the likelihood of fatal overdose. So I created 3 models based off of different risk factors. And I will link everyone in the chat. If everyone can visit this would be great. We're going to be playing around with this for a bit. So the point of this API is that anyone anywhere can create a website to intake data, and this data can be fed into my models or Inference Engine, and a risk score will be sent back. So here is the actual API. So I created 3 different models. There were a total of 76 risk factors that were selected based off of a wrapper algorithm. Basically, a wrapper algorithm, what that does is it looks at all the most important risk factors before you actually feed all the variables into a model. The point of that is that for a specific clinical decision support system tool, we don't want individuals to be too exhausted and fill out 150 questionnaire, for example. And so I basically looked at the performance of each model and based off of the variable sizes. So as you can see in the first model, there are only 10 variables. And then the second one, there are 44. And then the third one, there is 76, I believe. And so as we increase in variable count, the better the performance is of the algorithm. So for example, this is the string of data that I would require a website to send to this API. And with those variables, we can kind of see if we execute it, we have a risk score in the bottom. it sometimes takes a little bit. So as you can see here, 1 and 2. So 1 is the likelihood of non-fatal overdose, and 2 is likelihood of fatal overdose. And of course, these are just placeholders. It's just made up data. But in reality, we would request, there would be another end in terms of the website. The website would then have a questionnaire that would be based off of these variables, asking the individual, if they were using opioids, if they were using anti-craving medication, et cetera, et cetera. And if anyone is interested in terms of the methodology and also the performance of these models, I'm having another workshop at 1:40 p.m. today, in which I'll be discussing in depth in terms of how I created this, the performance, et cetera, et cetera. Yeah, and at any given time, if anyone has any questions, please feel free to type in chat or kind of, unmute. We're more than happy to answer any of the questions. So, let's see here. Let's go back to the slides.
Okay, so thank you for showing us your API, Andy. One potential way that the efficacy of CDSs can be tested, if you have noticed, is to compare the results of an assessment that a CDSS makes versus the ones that users make without utilizing a CDSS. So this is a clinical scenario of a 19-year-old male who uses cocaine 1 to 2 times a week. He is diagnosed with major depressive disorder and has been prescribed Prozac to take twice a day. And he has recently started experimenting with opiates and using it in combination with benzodiazepines. So I see a lot of people they work with people with lived experiences. So before we actually put this into Andy's API model, do people have any suggestions as to what his risk level of experiencing a non-fatal overdose would be? In terms of, if you were to give it a score between 0 and 100%, what do you think his risk level would be in having an overdose situation occur in the next 6 months? People can freely type in chat, or please feel free to unmute and speak up.
Hi, Nicole. We can also go into breakout rooms if everyone is very shy. Let me see how we can do this. Give me a second here. I'm going to stop sharing for a second here. We will jump into breakout rooms. So yeah, feel free to jump in those breakout rooms and discuss amongst yourselves, maybe give a brief introduction. Yeah. And we'll come back and talk about what we get from this question. Hello. Hello, Shannon. How are you?
Good. How are you?
I'm doing great. Yeah. So, what do you think about the 19-year-old male that's using cocaine 1 or 2 times a week. He's diagnosed with major depressive disorder and has been prescribed to take Prozac twice a day.
Mm-hmm.
He has recently started experimenting with opiates and using in combination with benzodiazepines. What is his risk level of experiencing a non-fatal overdose?
Extremely high.
That's great. Yeah. In terms of giving it a number, which
In
is
terms of giving it a number, so we're gonna do like a scale from 1 to 10.
exactly.
I would probably give him an 8 out of a 10.
Okay. How would utilizing a tool, so I just linked it in chat, the API that I presented, how would
Yep.
utilizing something like that assist kind of, would you rather something like a non-rule based or a rule based? And as I said, rule based systems, they're usually a little bit more descriptive. So they kind of like display EMR data, for example, and non-rule based systems are basically like machine learning models, right? That are algorithms trained based on database, and they just kind of have like a very like simple output. Like, okay, this is like, the risk score of an individual. How do would you utilize something like this within your practice? Are you a practitioner?
No, so I'm a nurse and I work with mental health and addiction. So I
Yeah,
see
that's
this,
amazing.
yeah, I see this type of situations and scenarios all the time. So I don't know. This one's kind of a tough one for me. I think I would go with the first one.
Right. So something that kind of displays a lot of different EMR data, etc. For
Yeah.
you to kind of, what if it was a combination of both? So I think I showed a slide where it utilizes both, kind of descriptive data as well as having, a risk predictive score based off of, a questionnaire that's developed from the ground up.
Oh yeah, definitely.
That would be better, right? So
Yeah,
I guess
absolutely.
something a lot, because I've also seen some papers that utilized electronical questionnaires based off of already existing questionnaires. For example, like the DSM, right? Like
Yeah.
DSM-1, for example. Would you trust something that, if, for example, I created my machine learning model and then I put it through a pilot study, right? And then I put it through like an RS randomized control trial where, okay, there is a difference that's being created. Would that make you feel more comfortable to use, my API, for example?
I think so. I think so. I mean, if it's factual, right? Then
Right.
absolutely. Like if you're not, like I think, yeah, like factual. If you're getting your information from the situations that are happening, for sure.
Exactly. So my question to you would be, wouldn't it be more biased for example, a panel of experts to create a rule-based system versus someone like me, where I'm just grabbing raw data from, for example, the CDC, right? And training my model off of that.
Yes. Yeah.
So yeah, so that's where I see kind of like the pros of my model, right? Whereas like
Yeah.
expert opinion will always have human intervention versus my model will always have, hopefully the most non-biased data out there, because it's just basically numbers that it's collected. Of course, healthcare system collections can still have biases. And yeah,
Exactly. I think in this type of situation and this type of category, it has to be
exactly.
non-biased regardless.
Exactly.
Yeah.
So that's kind of how I see my questionnaire versus, for example, even the DSM, right? Symptom-based, created by, humans. Yeah, how are you liking the presentation so far?
Oh,
Sorry, I think you just cut out there a little bit.
yeah, you were frozen.
Oh, sorry about that.
That's okay.
Yeah. Oh, I was just asking, how are you liking the presentation so far?
Yeah. Can you say that again? You were frozen.
Oh, again? Okay, I'm sorry. I was
Yeah,
just
so you keep
asking,
cutting out.
I was just asking how you like the presentation so far.
Oh, this is totally up my alley. So I'm super intrigued with all of this.
That's great. That's great to hear. Okay, let us go back to the main room and we'll talk about the next scenario really quickly. Oh, have you had a
Okay.
chance to play around with the API as well?
No, not yet. So I'll be interested in doing that.
Perfect. Perfect. If you have any questions, feel free to ask me.
Absolutely. Okay. Return. Okay.
Substance use.
Yeah.
Yeah. So Andy, we just had a question regarding like data collection and how systems can kind of account for protecting the privacy of individuals regarding their health data. Do you have any ideas speaking from like a machine learning perspective? You're muted.
Yeah. Yes, I do. Can that person ask the question again?
Yeah. Hi, Andy. My name is Musa. Let me just put it on the camera. 1 second.
Thank you.
Okay.
Hello, Musa. How are you?
Hey, I'm good. I'm good. Thank you for amazing, presentation. So, yeah, I said, and there are a lot of good things that machine brings us. One example is this conference, without so much uh, problem, we all together now communicating on this amazing conference and so on. But speaking of the algorithm, is just, it's run by corporation, and this is some sort of, my concern is what accountability, what level of accountability to hold the information, personal information, confident and in a secure area. So any explanation, anything in relation to this, until we have no regulation, how to go about this, how you explain it, I'm just not sure. Yeah,
Yeah,
please.
definitely. I can talk a little bit about like ethics and especially my project where I get my data from. So in terms of general kind of overview for machine learning algorithms, especially for pilot studies, for RCTs or whatever, they usually have to go through, ethics in terms of the governing body of wherever they're from. So for example, if I'm part of UBC, especially for my project, I'll have to go through, ethics, which I have gone through and have them approve in terms of like kind of the data that either I'm collecting or utilizing. So thankfully for my case, I've trained my model based off of BCCDC, so British Columbia Center for Disease Control's British Columbia Provincial Overdose Cohort, which is basically a data set that's been collected by multiple different local health authorities around BC. So because that governing body is already provincial, what they do in terms of that cohort of data is they collect data from, for example, Northern Health, Interior Health, from different bodies like Coroner Service and BC, so as well as emergency departments. And what they do is they de-identify all the data for me already. So the data that I'm utilizing does not have any names or anything like that. And what they do is they stick a Ministry of Health ID so that I can follow an individual throughout different data sets, if that makes sense. So all of that is then put into a secure environment within the province. So the data is hosted and located in a British Columbia server. And the only way for me to access is either I go to a specific facility, so I go to the CDC and utilize one of their computers, or I use a service called Citrix. And what Citrix is, it's a virtual environment and a virtual computer. And of course, before I actually can do that, I have to sign a bunch of agreements. I have to, make sure that, the de-identified data cannot be re-identified. And what that means is that I can't pull the data off of the actual virtual environment. And I have to sign a bunch of agreements. And then after that, when I want to create a model, right, and put it out like the one that you just saw within my API, I have to de-identify, I have to delete all the training data. So what that means is in a machine learning model, I'm using all this data to train, this algorithm. So the algorithm is basically just one line of code that is talking about the different weightings of the variables, right? So with machine learning models, when I create it, sometimes the training data gets stuck onto that actual one line of code. And what I did was basically I deleted all the training data, I deleted all the testing data, and I just have that line of code that remains. So I pull that line of code or that basically equation or algorithm, And with that, because it doesn't have any identifying factors, there's no data that even links with it. It's just a weighting, right, of the different variables. I pull that and I can then put it onto my local computer. And then after I put it on my local computer, then I beam it up to the cloud-based system, as you saw with the API. The API is basically, again, a service or an interface where websites can go on and utilize my model to see what the risk factors are for different individuals. Does that sort of explain kind of the whole picture, Musa?
Thank you for that. Yes, it does. However, your interest is, you're in a social work field. I get it. I respect it. I appreciate it. The information, but algorithm initially established by the corporation is not by the health provider. It's someone up there, they have their own interest. They, whatever their interest is, it's just a huge, huge scope of working on the information gathering data, so on. I am not sure when this data is just, going viral, or people know from the, different perspective, different area. I get it from the healthcare provider. That's fine. I understand. Thank you for that. But again, I leave it to the participants, what their intake. I just don't want to take over time. But again, yeah, thank you for this. So hopefully, this is going to be amazing tool for human being to, to serve in the health sector. Yes, it is amazing to, if purely health helps the health sector, I'm with it. I'm good with that. So
yeah. I think you're talking maybe about algorithms within other spaces, for example, like algorithms in like Google or Facebook. And I totally get it. Like there's a lot of data collection that's shady, etc. But for us, especially at the HCD group, especially with the like provincial, BC provincial health overdose cohort, that all that stuff is confidential. All that stuff is collected based off of the sole purpose of trying to, be a piece of the puzzle in terms of the opioid crisis. There's no monetary benefits or anything like that. I don't think. And they're really, actually, the BC CDC, they're very particular in terms of who they give access to. They're very, very picky about that. So that's something that I've had firsthand experience with. Thank you so much, Musa, for your questions. Let's go on. So does anyone from any of the groups want to share sort of their ideas? Because I know we just kind of came up from the breakout room there. I can sort of start if everyone's camera shy, which is fine. So I talked to Shannon. She's a nurse within the addiction field, and she had told me that she would be more comfortable. Actually, Shannon, do you kind of want to share your thoughts?
Yeah, sure. About the AIP?
Yeah, exactly. So the API, so the AI kind of machine learning. Oh, it's all good. And kind of what you feel more comfortable doing. So first off, you talked about rule-based and non-rule-based, and that you kind of prefer, a rule-based. And, of course, you can explain a little bit more why.
So I think just being a healthcare professional. So as a nurse, so right now I'm a nurse, but I'm working in an addiction worker role. So I think for me, as the nurse part, that's where the rules and that come in for me, because very rule-based, you have criteria to follow and you have a job to be done. And I feel like in this position that I'm in now with the addiction role, I'm not really following necessarily rules. I'm kind of going based off of the individual as a whole, because now I'm out in the community doing outreach work. So now I am basing all of my information and what I've gathered from these individuals themselves. So I think this thing would be fantastic because I'm getting that firsthand knowledge of the addiction, what substances they're using, the amounts of overdoses, and just resources available to them and not available to them, the lack of resources and what they would like to see. So I think both together for me is something that I would put to good use.
Right. So something like a rule-based system where they kind of talk about guidelines that already exist, that are
Yeah.
proven, for example, like DSM and stuff like that. And then a non-rule based, which is like basically all this data that you've collected, Shannon, can then be put into an algorithm that's been trained based off of, hard data from the CDC, for example. And then it can give you like a risk score. And at the end of the day, all this is just supporting kind of your efforts of, treating, the vulnerable population, right? It's not a replacement. It's sort of there for you and assisting you in a way that you wanted to.
Yes. And exactly.
Perfect. Yeah. Does anyone else want to share kind of what they kind of discussed in the breakout room?
I think this goes back to like the overall idea that CDSs are for the clinicians or the patient use, and they're not to replace like human interaction in any way. So there will be people who are, hesitant to like share their own data with the system or be more willing to talk to an actual person about their problems. And I think that's completely fine. Like there's no way that systems will ever replace that kind of human to human interaction that we all need as doctors and patients. And I think that CDSs and others like systems can help like people like confirm their own ideas or like recommendations to a patient and serve as like aids in decision making. But if we're all things together, I don't think that it would be like replaceable. So people with more experience have shown to prefer like their own decision making and instead of using like a CDSS, which is completely fine. But I think our point is that we want to have it available for anyone if they want to use it, as well as there are patients that prefer to be, anonymous or not speak directly to a person, but to like a computer or to the internet. And that's totally fine. We just want to have the like all kind of options available for them, I think is our goal at the end of the day.
Yeah, definitely. Okay, so why don't we move on to the rest of our presentation? So this is sort of the second question, and I think the point of this question is to kind of show that the difference between this question and this question is very similar, right? And it's very hard for at least me, or hopefully you also feel the same way, to distinguish between the two, right? What is the difference between fatal and non-fatal overdose? What are the key risk factors? Can you come up with, for example, a number in terms of the differences between the two? Yeah, let's discuss that. So the difference between this question is that instead of just asking what his risk level for experiencing a non-fatal overdose is, now we're talking about a fatal overdose. It's the same individual. What is their risk level of experiencing a fatal overdose? And we will go into breakout rooms again. Let's see here, breakout rooms. Hello again.
Hello.
Yeah, so I can read the scenario again for you. A 19-year-old male uses cocaine 1 or 2 times a week. He is diagnosed with a major depressive disorder and has prescribed to take Prozac twice a day. He has recently started experimenting with opiates and using in combination with benzodiazepines. What is his risk level of experiencing a fatal overdose?
I would say at least an 8 out of 10 again.
That's great. What would be the differences between a non-fatal and fatal, for example?
Well, a non-fatal, he would have came back, obviously, right? We would have brought him back. And a fatal one, he'd be deceased.
Why would the risk score be similar in the two?
I think just with the amount of opiates that this individual is using and just the mixture of medication that he is using, right? So his risks to me are the same. It's
Right.
just, will he overdose and be successful or non-successful?
Right. Yeah. So polysubstance use is something that is, of course, a high risk factor. So because he's mixing, for example, is a big deal. Yeah, that's great. I think that's sort of the point of this slide is to just kind of make is that it's so hard for, especially, like a case manager or, a nurse or, a doctor to distinguish between the two, right? They're so similar. And so for me, there's a lot of value to be taken away in terms of like, utilizing a non-rule-based system where you're finding the minute details of, okay, mixing these two, there's an additive effect that maybe I didn't know about. And, it's hard to know about because there's so many different drugs out there. There's so many different scenarios out there, right? But we can now detect because of this tool. So
Yeah.
yeah, okay, that's great. Let us go to a different room. Let's see.
Okay.
I'm going to chuck you into room 4.
Okay.
Have you been put back?
Hello.
Hello.
Hi.
How are you? How are you doing?
Good. How are you?
I'm doing great. So what do you guys think about that specific question that I just asked?
So I don't think we read I wasn't able to read the whole thing carefully enough because you said, yeah. So because the thing is I work with addicts and I've worked as a harm reduction worker. So someone can overdose quite easily, even though it just depends on the drug. It depends on the strength of the drug. It depends on whether they got it from if it's the same source, if how often they've used that amount. Like there's a lot of and it's probably more complicated in my head than it would be for other people who haven't worked in a safe injection site.
Absolutely. I think all of that matters, and all of those are basically data points that I see. So let me kind of pose a question again so we can kind of talk about it. So the first question was basically the exact same question that I'm posing now, but instead of what is his risk factor, what is his risk level of experiencing a non-fatal overdose, we're now asking what is the risk level of experiencing a fatal overdose. So this is the scenario. A 19-year-old male uses cocaine 1 or 2 times a week. He is diagnosed with a major depressive disorder and has been prescribed to take Prozac twice a day. He has recently started experimenting with opiates and using in combination with benzodiazepines. What is his risk level of experiencing a fatal overdose, and how does that compare with experiencing a non-fatal overdose? So of course, dosing matters and all, but yeah, I think the overview of this question, or the reason why we kind of posed both of these questions, was that it's very hard, even for experts, right? It's very hard to distinguish between the minute differences of experiencing a fatal versus a non-fatal, right? And so I think the point of this was to say that, having a non-rule-based machine learning system built on data from the CDC, you can then see these additive effects that you might not have been able to detect. Based off of an algorithm that can kind of look at all the different interactions based off the data points. Of course, there are a lot of cons. There are cons with it. For example, like you don't have maybe the resolution that you would want for dosing, for example, if the questionnaire isn't detailed enough.
Yeah, and that's what I think we were talking about, was it depends on where they get the opioids, because even that changes depending on the dealer you get it from. And sometimes even the same piece of fentanyl, let's say it's fentanyl, the same piece of fentanyl, one part of it isn't as strong as the other part. I've seen this happen over and over. So this is a really difficult thing to predict, because just because they didn't off that first shot and they do the second shot and all of a sudden they're overdosed, it depends how many shots they do. It depends, like it depends on a lot. And we deal with a lot of overdoses. I mean, we use oxygen a lot. So it's there's so many factors in there, and it depends on if it's fentanyl. Fentanyl's so unpredictable, and we could have someone come in with the same piece of fentanyl and one person's overdosing and the other one's not. The tolerance is also a thing, like how much tolerance they have. If this is the first time using, we always tell people to be careful and make sure you use only a little bit and try, like a tester, we call it, so that to see if they're going to overdose or not, or how they're going to react to it. Because if it's your first time, or it's the same thing if someone comes out of jail, don't use what you did before you went into jail.
Right,
Just
right,
do a small amount.
Right.
Like, and if they have other medications on top of that, we don't always know that. So it's on the perspective, like even as a social worker, now I work as a social worker, I don't know what they're like. They may tell me, oh, I just use fentanyl, and then they're going down. I don't know what else they may be on all the time.
right. So it's
Because
hard for you to utilize a tool like that, because then, I guess my follow-up question, not to kind of interrupt, is would you kind of utilize something like this for, assisting you in terms of determining if an individual is, at high risk for fatal overdose, for example, so that it can, change as a, as a social worker, as a caseworker, be able to connect them to other, maybe beneficial resources before that sort of fatal overdose happens? Do you think you would utilize something like that? Do you think it'd be helpful for you?
it would be helpful, and it would also, I mean, especially if it has information on the client, like, because I do use an EMR, so I do know what medications are. The
Right.
thing is that I don't always have the medical knowledge to know.
Exactly. Yeah.
This is where the problem comes is that I don't have the medical knowledge to know
Neither do
what drug
physicians sometimes.
interactions are. Yeah.
Neither do
Like
physicians. How would they know what, this specific drug will, deal, how does that interact with another? And with that EMR, you can basically utilize that and, okay, fill out, this questionnaire for the patient, for example, and get out, okay, oh, wow, okay, these drug to drug interactions might be super problematic, for example. And yeah.
So if I had that knowledge and there was some way for me to know the interaction so that I would know, because I mean, I have clients who don't even know all the medications are on. Let's be honest. Some of them are like, I don't remember all the medications. Like, and I can go in the EMR and look for them and find them. But I mean, and some of these things help, like I forget what it's called that we use at work, but when the doctor goes in to check all the medications they're on, because I mean, sometimes they're getting prescribed from more than one doctor, and I mean, it doesn't happen as much as it used to, but it does still happen.
Yeah. I think another key piece is that for data collection, for example, there needs to be more data collection happening, because, for example, like something as important as fentanyl, that isn't really being collected from the CDC, and because it's hard for them to, right? So because it's a passively gathered system from the CDC for like the British Columbia overdose cohort, it's hard to find that resolution. It's hard to find data points on whether or not individuals taking fentanyl, because it's not being tracked, right? People are going to the corner service of people are dying, fatally overdosing, and then only at that point are they seeing, okay, there's fentanyl in their system. But for the rest of the individuals that are overdosing and not passing away, it's almost next to impossible, right? Because doctors aren't prescribing fentanyl, it's street fentanyl. And so that's a data point that I'm missing within my model, which I think is a key piece to, the fatal overdose and non-fatal overdose problem.
Well, yeah, and it doesn't help. Like we used to have drug testing machine, but ours isn't working now. And that used to help because we did have clients who would say, look, can you test the rest of what's in my cooker so that you can see what took me down? Because I mean, we save lives. We save lives almost every day. But they want to know too. And it's interesting when we see what we get, but now that we don't have that, I mean, and there's not a lot of those machines around where we can test and see what's in the drug supply. That would be important, because I think that would be helpful also for the doctors prescribing to know this is what's happening. This is the trend right now, because the trends come usually from Vancouver. I'm in Ontario, from Vancouver down to us. Usually it happens in Vancouver first and then floats this way. So but it's always a trend. So, when you read in Vancouver, this is happening in Vancouver, it's going to be in Ottawa within the next month. So, and that's helpful. It helps us to know, okay, this stuff is coming. So we prep for that, and we know it's coming, and we know it's going to happen. And we used to be able to tell by the color of the fentanyl, by the color, like, oh, it's purple. So the purple's okay, but the blue's not. But that changes because, as I said, like they change the color because clients get wary. Oh, we don't want the white fentanyl because that's got carfentanil in it. And then the dealers change the color of it because nobody's buying it. So, it becomes really hard, but I do find this process interesting. And it would be helpful. It would also be helpful though, if it had, I think it would be really helpful because like I said, I don't know these medications. So for someone who's not a doctor,
Mm.
like knowing interactions, knowing what does not go would be helpful. So yeah, I do think it's interesting, and I do think it would be helpful. So long answer to your question.
No, that's great. That's what we're here for. We're here to discuss. Thank you so much, Lisa. Sarah and Randa, do you guys have any comments?
Lisa, I don't know where you are in Ontario, but I'm in Sudbury, and I definitely agree with you when it comes to testing of the drugs that these individuals are taking. I would just like to see it being offered more than just a select few places.
100% agree, because that's the only way we're going to get, I want to say ahead of the, I'm in Ottawa.
Okay.
Yeah, and even here, like getting drug testing is almost impossible. I mean, there's fentanyl strips, but those aren't accurate.
Yeah.
And they don't test for other things. They don't tell you what's in it.
Okay. So we have
yeah.
something here in I'm in Sudbury, and it'll tell you what's in it, but I want to say we only have 1 to maybe 2 places that actually offer that. And if it's not in the downtown core, like where all of our users frequent, they're not going to go.
No, and you're right. And when they say, well, I'm on this medication, this medication, this medication, and then they're like I said, I'm not a doctor. If they say they're telling me they're on this medication, then they're putting fentanyl in, I'm like, I don't know what the interaction. Now we do have nurses in our CTS, but I'm not in the CTS, in the safe injection site anymore.
Yeah.
So when I go see a client, they're like, oh, they just, they've used, and I don't know the medications they're on. So, this is where it might come in handy, is because if I don't know what medications they're on and all I know is they did fentanyl, like that's all I can tell someone when I call 911, right? Is like they've done fentanyl and I don't know what medications they're on. So
yeah,
I don't know, maybe we need to be more aware when we're working with clients, have a list of them. I don't know.
Yeah, I don't even know what the right answer is. So I'm a nurse, but I've been working as an addiction worker and doing lots of outreach. So I'm seeing just a different side of like the world of addiction. So yeah, I definitely think like even outreach workers should be able to carry, things on them in order to test it and advise those individuals right then and there too, right?
Yeah,
So,
yeah,
yeah.
yeah.
Lots of things could be implemented, but yeah.
Well, it would be nice if there was an app. But the thing is that like when we talk about clients, because a lot of my clients are homeless and a lot of my clients are on ODSP, so they don't have money. A lot of them don't have phones, don't have internet access. So for a lot of them, an app wouldn't be really helpful.
No.
But
Right. It's more so like clinician, like we want to make it so that it's a decision support system for clinicians, because this is one of the problems that I kind of came up with, which is like, if we do client side stuff, patient side stuff, it's hard because they don't have smartphones. It's hard because they're just not interested. They're kind of disengaged. But if we try to target the social workers and the healthcare workers and try to help them with decision making, then maybe we can make an impact there, right?
Well, and so what are the legalities there though? Like if someone, so I would be afraid, like if someone said, oh, if I mix this and this, am I okay? And I'm like, well, it looks like it's fine. If it's not fine, then am I going to get like, am I going to get, like I'd be afraid that I'd give them, even though an app tells me it's fine, is it really fine? Because again, I may not know everything that they're doing. And unfortunately with the clientele I work with, they won't tell you. Like they'll only tell you what they want to tell you.
Yeah, I think that definitely be a situation where it's sort of a very gray area, and I would just definitely be like, with caution. I think all these tools come with that, right? Where it's like, okay, you have to understand utilizing this. You can't, this isn't the be all end all, right? At the end of the day, have to use your judgment, and there is, error with these machines. So, right, like nothing is perfect, right? These machines come up being 80%, 90%. There's still that percentage of where they get stuff wrong, right? So, there's definitely a caveat with it.
No, and you're right. You're right. And I mean, I'm glad it's not really for clientele, because I'm one of those who will go on WebMD, and sometimes it tells me I've got all these serious things wrong, and I go to my doctor and I'm like, no, it's just you're in your 50s. This is what happens. It's normal.
Right. Yeah.
And so I would be a little cautious about putting something for a client, but yeah, I mean, having something that I can look at and have some idea of what interactions may happen is a good idea and is interesting.
Yeah, thank you so much. We are running out of time, so we are going to go back
sorry.
to the main room. It
Thank
was
you.
great discussion. Thanks everyone for being
Thank you.
interactive.
Thanks, Andy.
Okay, we will let's go back to the main room.
Hear from everyone lived experiences, see what they favor and what they would like on a systems level.
Yes.
Yes. Andy, would you like to carry on?
Hello. So we are running out of time, unfortunately. And so are there any other last minute questions, burning questions? If not, if you guys have any questions for me in particular in terms of, our systematic reviews or our projects or what we're doing, I'll type my email in chat right now. And you guys can also message me on Huba. But other than that, have a great rest of the conference, and I'll see you guys. I'll see everyone later. Thank you.
Thank you so much.
Bye, everyone.
Thank you.
Thank you for coming.